Hi, I'm Kevin Rosenbloom, here today to show you the Rosenbloom method, a method utilized for capturing negative impressions of the lower extremity to manufacture Crow braces, A braces, custom orthopedic shoes, custom G braces, and T braces. Essential items you will need: a 5-inch roll of plaster of Paris, a basin of hot water, exam gloves, order form, permanent or indelible pen, and a drape, either tissue paper on a roll or a drape that you'd use in a surgical setting or a clinic setting. Optional is a stockinette or pantyhose used for mostly male patients that have hair on their lower extremity. Also optional is a leg lifter. Okay, real quick, we'd like to show you how to properly trace the foot for custom tundra boots and custom orthopedic shoes. This tracing is required. It really helps to determine how much the foot splays upon full weight bearing. So Laura, go ahead and stand up completely. And I want you to allow your knee to roll in, see how much we can get your foot to splay out. Very good, thank you. And this is really nice just to see how much you're actually going to pronate here and the amount that we're going to need to accommodate the medial aspect of the custom shoe. And I take my pencil or marker and I hold it vertically like this, possibly with 1 or 2 degrees into the body of the foot, but vertical is ideal. And we just come around vertically, following the contour lines, and if it hits the malleoli at all, that's fine. And the toes, we want to get an accurate idea of how the toes are shaped, like that. And that looks great. I'm going to lie this protective barrier down. Go ahead and lift your feet up. Thank you. I'm going to take our plaster and prepare it into 12-inch pieces. And we're going to prepare our 5-inch wide roll of plaster into approximately 12-inch or 15-inch length splints. If it's a larger foot, I'll go 15 inches, or we can just double up and wrap the foot as necessary with as many pieces of plaster as necessary. And we'll do this relatively quickly. And this can make a mess a little bit, and you can see I'm getting it on my shoe slightly. I'll tuck it underneath this paper. The ripping process gets plaster dust in the air. Sometimes it helps to have a medical assistant do this beforehand and prep splints, or you can buy splints that are already cut. We stock those. And these I'm going to rip into a couple of pieces just like this that we'll use. Okay, great. Now I've got 1, 2, 3, 4, 5. That's fine. I'm going to use 2 on the bottom, and we're going to do 3 on the top. I'm going to take the leg lifter, place a towel over the metal bar just to give the patient a little bit of comfort, like this. And I like to put the surgical basin right underneath the foot like this. And I'm going to line up essentially the bottom of the foot, planing down it as if I was casting for a neutral suspension slipper cast, and get an idea as to how I'm going to hold and apply the plaster splints and what position we want to be in. I'm looking at the second toe, the knee, and her ASIS, anterior superior iliac spine, for neutral alignment. I'm going to dip the plaster into the water and wring out the water like this, wrapping the back of the calcaneus, centering the calcaneus in the middle of the splint, and then tacking the ends of the splint on top of the first metatarsal and about the fourth metatarsal. And this is just like gift wrapping to get a smooth, even surface on the bottom with the plaster so we don't have any irregularities with the plaster. Usually the first splint that I apply, I like to leave it pretty moist because it's going to have the longest preferable time to dry, whereas the last splint, I like to wring out the water as much as possible so we have quicker drying time with that splint. One or two swoops with the thumb and the index finger to really paint that plaster splint onto the foot. And then I always like to grab the first toe and the fifth toe and kind of spread them out to give you a little bit more comfort feeling on their toes. You don't feel so squished in here. And it also allows everything to kind of splay out and be comfortable. So that looks really good. And depending on the patient's architecture, whether or not they're easily pronated or easily able to hold a good architectural position that we're looking to create with this negative cast, we can wait in this position and really get a good neutral cast. So when you do bring this foot down to the ground, it will not pronate. The plaster will actually support the foot. Given Lauren's foot architecture, just by placing her at 90 degrees, she holds a fairly good position. So I'm going to go ahead and speed up the process and just bring her right down to the ground. And with her semi-weight bearing in a seated position like this, she'll have good contour for this type of brace that we are crafting. I'm going to position her right at 90 degrees, and don't be afraid to set her down, lift her up, and move her around again right in the position that you're looking for if you don't get it right off the bat. If you're looking to supinate the foot, it doesn't hurt to adduct the foot or give her a little bit of an in-toe. And if you're looking to pronate her a little bit more, then you want to basically abduct her foot or give her a little bit of a position like this. You can also put your elbow or your forearm onto her, the top of her knee, and put a little weight on here to see how she does with a little bit more weight than she would if she were to fully step down on the foot. You can see how she kind of pops up after I release that weight. But this is a great position right here. I'm very happy with that positioning. And now we're going to apply the splint. I'm actually just going to roll you in, Laura. If you can hold your foot right in like this. One of the things I'm really looking for here is the amount of roll-in that we experience with the medial malleolus right here. This can be an issue, and we want to accommodate for as much pronation in this medial malleolus as possible. Someone who overpronates significantly, you may see about 2 centimeters of displacement going medially when they fully weight bear. And so we do want to accommodate, so we do have that final brace, and the position, it's not causing any irritation or hot spots. Sometimes you'll find it along the talonavicular joint and the talus head and the navicular, or if there's an accessory navicular. These are problem areas typically. So we do want to accommodate for those. Take note, and even on the cast, if there is a significant amount of bulging or movement in this area, you can mark it with your indelible or your permanent marker, and that way the laboratory is well aware of what's going on in certain areas, and that we need to possibly add 2, 3, 4, 5 millimeters of plaster on the positive cast so we can accommodate this for the patient. You can also put that permanent marker on the skin, and that'll transfer on the inside and then turning out to be, in fact, I'm going to do that now. I'm going to set this aside. Don't be afraid to set your plaster aside here. I'm going to put marking right on the medial malleolus right here. And that's going to translate real nicely. Let me get it a little wet, actually. That's going to translate real nice on the inside of the cast, so when you look at the positive mold, you'll be able to see accurate landmarks. Okay, and I'm going to look for maybe about 1 inch to 1/2 inch of overlap right here on the top of the slipper cast, and just fold over right here, leaving that anterior seam. This is really what we're going for with the Rosenbloom method, and this is what makes this so easy compared to the other methods that are out there, which require cast saws, surgical hose, letter openers, scissors, whatever you may need if you go and do a full wrap. This is a very clean and very simple method of doing this. And I find that you can modify this for almost any deformity in pathology or any type of presentation that you're working with. Again, using my index finger to hold the top part of the splint, and then paint this splint back in so it's nice and creamy and has a good purchase onto the leg and the skin. Those little strings can get in the way, but I'm not too worried about them. apply the last splint. Okay. Painting this on, making this very smooth and creamy, like this. And at this point, I'm going to cover this which you can do at the beginning. Probably it's smarter to do it sooner. Get nice placement on the anterior aspect of her distal foot like this to cover this up. And just for precision reasons, why not we cover this little piece over here like this. I'm just going to rip off the amount that we need and apply this on the medial dorsal aspect of the cast. That's it. Perfect. Now we wait for this to dry. You want to hear an audible tap. Down on the bottom here we have a nice audible tap, but these are fresh, so we're going to give this about 4 minutes, maybe 5 minutes until that hardens, and we'll remove the cast. This up here, it's a little soft still. I can see the skin moving and the plaster moving, so we know that's not just hardened yet. I'm going to prep my splints. And these couple pieces we'll use to hold the negative cast in the right position for shipping. This looks as if we're ready to remove it. It's nice and hard everywhere. The little top pieces, the last pieces we put on, are hardened. And I'm just going to twist your calf around like this and pull up slowly in the back of the gastrocsoleus here and really separate it. And then Laura, go ahead and lift your knee up towards the ceiling. Go ahead and pull it off the bottom. Great. Clean off the bottom here. And then extend your foot out like this. And at this point, I'm going to separate this top part here. And sometimes it's a little hard to pull the cast off of the back of the heel, especially if someone has a very large posterior calcaneus architecture. And if that happens, I actually like to take the front of the cast and open the front of the cast like this and remove it from the anterior aspect, actually ripping the front like this. You can come across this way, and that makes it a lot easier. And if someone has a wound, a diabetic wound or an ulcer, this also makes it a lot easier to rip the front part open like this, separate it, and actually pop the cast, separating it from the skin, just like that. A little bit easier. And here you can see where we put the medial malleolus indicator right here. It's translated very well onto the internal aspect of the cast. And when we pour this at the laboratory, this will translate onto the positive aspect of the cast. And we'll see that in a little bit once we get to the lab. And we have a perfect indication as to where to put that extra buildup on the positive model. From this point here, I'm going to bring the cast back together, overshooting just a little bit. And I can cheat just by looking over here and say, okay, we need about this much space. You can see that's translated pretty well from here to here. Same thing on the top of the foot, kind of lining this all back up. I'm going to take these few pieces of plaster we have left over and bandage this cast up so it's solidified for shipping. This is really important. And you really want to let this harden in your clinic for a few hours, if not overnight, if you can, if it's not a rush order, so it's nice and solidified for shipping. Sometimes we'll receive casts that are deformed because they've gone through some rough transit and they were not 100% dry when they were packaged. And if that's the case, this plaster will constantly be releasing moisture, and if it's sealed in a box, the moisture doesn't have anywhere to go. So it's nice to let this dry so it's There's no moisture or very minimal moisture. At this point, we're very happy with this. You can even stuff this with newspaper or wrap it in newspaper in the box. And there's our finished cast. We've just completed the Rosenbloom method, and we have our negative impression. Off to the lab. We'll see you there.